Good morning, everybody. Thank you so much for joining us today. You should be here for the Introduction to FASDs webinar sponsored by the Frontier Regional FASD Training Center, which is funded by a grant from the Centers for Disease Control and Prevention. I'm going to be going over a few housekeeping announcements before we begin today's training. Please refer to the notes box on the right-hand side of your page to see important announcements from me, Carolyn, the moderator. I will be addressing questions related to technical difficulties there, and I have already posted some information about audio help if you're experiencing audio issues. Participants will be muted during today's webinar. If you wish to ask the presenter a question, please use the chat box in the bottom left-hand corner of your screen. You can also use this box to communicate and chat with other participants. Next to the chat box is the web links box. We have included some resources in this box along with webinar evaluation post-test. You may navigate to the linked website by clicking on the website name and then press the Browse To button. As we talk about resources today during the webinar, I will add them to the web links box. Finally, if you did not pre-register for today's webinar, you will not be receiving a certificate of completion. You should know if you pre-registered because you should have filled out the online registration form and received a confirmation email. If you haven't registered, please let me know and I will send you the registration link. And now I'm going to turn the presentation over to Ryan Tolis and me.
Thanks, Carolyn. I hope everyone can see me here. I'm presenting from Missoula, Montana here on this Thursday. I know as we move our way through this information, there'll be others that will join us, and there may be some slight glitches along the way, so if you're able to get a hold of Carolyn, let her know what those might be. That will help us to move forward here swiftly over the next hour. I have lots of information both in the area of prevention and in treatment, and there will be times when you might have questions that you run into, and if that happens, we'll be stopping at different points in time, once about halfway through before I show a video, and again at the very end. There'll also be some resources I will identify while we make our way through this presentation, and if at any time you want to know more about those resources, you could go ahead and put that in the chat box, or I'll also have a slide at the very end of the presentation, and it'll list those resources as well for those of you who might be in different fields that may be looking for specific types of information. As Carolyn mentioned, my name is Ryan Tolis, and I'm the chair of the School of Social Work and at the University of Montana. And I have been in the area of fetal alcohol syndrome, which was originally called many years ago, beginning in about 1984. Before I get into that history and talk a little bit about a case study, one of the things we're going to do here is have a couple of polls along the way just to find out a little bit more from you and give you a chance to participate. This first poll is, I hope, visible for all of you. There it is. And we just want to have some idea of how knowledgeable you are about FASDs. Give us some idea of whether there's some knowledge, no knowledge, well-versed, or an expert in the field. And that will help us a little bit. Good. Well, it looks like most of you have some knowledge, and others it might be the first time here to learn some of this information. And again, if there's anything along the way that you don't understand and you'd like more information about, we'll stop at a couple of different points so that you can ask whatever questions you might have. Make sure that you get the information that you need. As I explained before, my interest in this area began back in the 80s when I was working with youth during that time that presented certain difficulties for those of us that were working with kids that were in foster homes and had a difficult time being able to stay within their own biological families. During that time, we had many children that came through our doors that we just had a hard time being able to understand, and at that time didn't know much about this particular disorder, as it was just beginning to catch a little bit of traction in the early 80s. I remember specifically one young gentleman I was working with who had very good verbal presentation skills. He communicated quite well, but it seemed like every time we would work on portions of his treatment plan in an effort to help him get better, he would inevitably not be able to follow through. And we were frustrated with his actions. There were many times that we thought, boy, he's just going to continue to excel and do better, and he would inevitably go back to the starting point. And it seemed as if he wasn't able to learn and understand what we were talking about in our treatment plan, and the family was getting increasingly frustrated, attempting to meet the needs of this young man. And then it wasn't until a few years later that we learned that his mother, biological mother, died of alcohol poisoning. And it began for me then a process in which I was attempting to learn more about this biological connection between what he had been exposed to prenatally and what we were seeing in him as a young adolescent at that time. And over the years, I've been able to follow his progression as he's matured into an adult now, and being able to see just some of the difficulties he's had with this particular disorder. In 1973, this is the first time that this, which is oftentimes referred to as a discovery, was made, where this diagnosis of fetal alcohol syndrome, or FAS, came about. There was a team of researchers at the University of Washington who began to see that there was a specific correlation between the offspring of alcoholic mothers and then these consistent physical and central nervous system deficits or impairments that they were beginning to notice. And so although there was some reference to there being a cause-effect relationship between mothers that were consuming alcohol during pregnancy and the offspring, a lot of it was disregarded, and people didn't believe that there was a connection between the two. So it wasn't until 1973 that this official discovery was made, and we then had a working diagnosis for us to begin to understand at least the etiology or the origin of this particular set of symptoms or impairments that we were beginning to see. Shortly thereafter, there were attempts to make sense of other kids that we were seeing that we weren't quite understanding them as well. They didn't have many of the facial features that are associated with fetal alcohol syndrome diagnosis, and these particular children appeared to be normal, again, not showing any particular facial abnormalities, but had some of the central nervous problems and some of the learning difficulties that we were seeing that are also consistent with FAS. And so a term called FAE was then adopted, or fetal alcohol effects. This was in place until about 1996, when then this umbrella fetal alcohol spectrum disorders came into place. But up until that time, that FAE term was being used. And you may still hear it from time to time. What if somebody has FAE, but that FAE diagnosis has essentially gone away, although it still creeps in from time to time. I think part of the change, too, was that there was a lot of overlap between kids who had a diagnosis of FAE and children who were viewed as being oppositional or having conduct disorders, or perhaps an attention deficit hyperactivity disorder. So there's a lot of confusion. And so the alcohol spectrum disorder umbrella was put into place to help us better make sense of all the different possibilities that this continuum of abnormalities.
All guests have been muted. You can unmute your line by pressing *6.
I hope I'm okay to keep going here. I just got a message from someone, but I'm not sure who that was. All right, I will continue on here. So this fetal alcohol spectrum disorders, or FASDs, provides this continuum going from mild impairments to more severe on the far end of it, which could lead to profound disabilities and death. It's important to know that these are caused by prenatal alcohol exposures and are in no way hereditary. I was given a presentation a couple of months ago, and there was a question related to that, whether there's any hereditary connection here in terms of genes making their way from the mother to the offspring, if the mother was in fact diagnosed with FAS. And there's not a hereditary part to this. This all has to do with this prenatal alcohol exposure and alcohol consumption in utero. This is also a diagnosis that's made by a physician, not one that can be made at this point in time by a counselor or a therapist of some kind, but is made by usually a specialist that is able to detect this in newborns, that being perhaps a pediatrician or dysmorphologists, they're known as, that may oftentimes be making this particular diagnosis. We have some different terminology that's associated with the umbrella, again, this continuum, the spectrum of disorders that we have in place now. I'm going to first start down here with FAS and mention this a little bit here. Again, we have this umbrella of terms that are associated with the spectrum of possible disorders. The first one here, FAS, that I'll begin with, characterized in 3 domains primarily, that being in growth impairment or growth retardation. So you oftentimes will see children who are smaller in size. Head circumference may also be smaller. Again, their growth is not at a normal or typical range for their age. We'll also see central nervous system or neurobehavioral kinds of abnormalities with FAS diagnosis, that being the second criteria. And the third being one, as I mentioned before, with these facial features that you'll oftentimes see that are very specific facial characteristics that are noted with a child that has been diagnosed with FAS. As I mentioned before, as I move up here to FAE, fetal alcohol effects, like prior to 1996, this was a term that was used oftentimes. This has been replaced with the similar kinds of impairments or deficits that are primarily neurobehavioral. So this is termed alcohol-related neurodevelopmental. Make sure I get this correct terminology here. We're looking at neurodevelopmental disorder. So alcohol-related neurodevelopmental disorder, ARND. So this again describes functional or cognitive impairments that are associated with the spectrum and does not display the facial characteristics that are specific to the FAS diagnosis. Those are the 2 that are most commonly used now. The other that person may see from time to time is ARBD, or alcohol-related birth defects. And this may be, we'll get to this in a little bit as you see some of the different areas that can be impacted by alcohol consumption in utero. Maybe, there may be some heart ailments or skeletal kinds of disorders, may affect the eyes in different sorts of ways, kidney, ears, that you may see this ARBD that's used. The last one here we have here at the bottom is PFAS. And this brings us to our next question. You know what FAS, excuse me, is at this point, but I want to ask you what this P stands for, so you could chime in here and take a look at looks like the vast majority of people are going with partial, which is correct. So it has partial fetal alcohol syndrome. So it may be that some of the facial features are present, but not all. And so you are correct if you answered that yes, in fact, this may be partial fetal alcohol syndrome. That may be another diagnostic category that one may run into from time to time. Again, that's a part of this spectrum of FASDs. Now, I want you to take a look a little bit here at some of the prevalence rates so you have some idea of just how frequently we end up seeing some of these different types of disorders that fall under the umbrella of fetal alcohol spectrum disorders, FAS being the most common within that category. This is the most severe and one that is the most debilitating. As you see there, with 1,000 births, you're looking at between 0.2 and 1.5. Difficult to accurately determine because it's very difficult to diagnose, and some people aren't trained to diagnose that particular disorder, so it's maybe difficult to get that nailed down real well. So the best estimate and conservative estimate is between 1,000 and 6,000 per year. For many of you that might be professionals working in the field, you can begin to see how some of the services you provide and how much it ends up costing in terms of whether they be educational services or perhaps It might be in the mental health arena. There's justice systems that get involved, early intervention programs, disability systems that become a part of an individual's service and resource delivery system that end up costing an incredible amount of money. Here you see all the FASDs included here along the spectrum between 9 and 10 cases per 1,000 births, so about 40,000 affected births per year, and lifetime costs are about $1.5 million. And again, many of you who work in the field probably have some idea of where that money gets put in around education, mental health, justice system, and all the other systems that are oftentimes a part of working with children who have this particular one of the disorders. What I'm doing here now is I'm going to show you here a fetal development chart that will give you some idea of development of the embryo into the fetal stage. This will help give you a little bit of an idea of kind of the critical period here that is important to pay attention to, especially during this embryonic stage or during this first 8 weeks, especially. As you can see here with the development, especially beginning in week 3, you'll see a rapid amount of development that's happening with regard to the central nervous system. So the central nervous system consisting of the brain, spinal cord, you have a tremendous amount of growth that's happening during that time, where you have neurons that are developing and they are multiplying very rapidly. They're dividing, they're beginning to communicate with one another. And this is when an especially critical time during fetal development to make sure that a child is ensured the maximum of development, the most healthy development is during this critical phase in terms of their central nervous development, making sure that their brain has optimal neural development. And this is something that can be impaired very significantly during this first period of time. And again, as all of you I'm sure know, that this first trimester again is one oftentimes when many women, especially those that are planning a pregnancy, would have no awareness of the fact that she might be pregnant, especially if it's a first pregnancy, and oftentimes it can be a second or third. I'm a father of 4, and so there were many times that my wife might not have known that, in fact, she was pregnant during that early period when, in fact, she was planning and thinking about and paying very close attention to it. So you could imagine somebody who wasn't planning a pregnancy or somebody who was young and sexually active that perhaps she didn't know her body well, that could certainly be exposing that embryo to these toxins during that time that would have very detrimental impacts potentially as a result of consuming alcohol. Now, this obviously is not a woman in her first trimester, but I just simply have this slide in here to as a reminder of this development of nerve cells during this time, and this normal development of nerve cells being impacted by or interrupted or disrupted by alcohol consumption, so that this normal expression cannot happen. Again, the production of cells, the growth, the division, the multiplication being affected, in addition to the ability of these neurons to begin to communicate with one another, and certain genes also not being able to be expressed during this time as a result of this alcohol that surrounds the fetus during this particular time, as a mechanism that during fetal development, women essentially carrying the alcohol within the placenta that surrounds the baby that has really no ability to begin to use their kidneys to process that alcohol, and in fact is simply bathing in alcohol to some degree. So the CDC has said, there's just absolutely no safe time to drink alcohol. There are many people who say, well, maybe that during the second trimester, third trimester, or if you only drink a certain kind of alcohol, that there not only is no safe time, but there's also no safe type of alcohol or no safe amount. So certainly there are many women out there that say, well, gee, I drank during my pregnancy and nothing happened. That may be possible for some women. But it's also affected by many other factors too that may have to do with one's diet, those kinds of things. But whether it's beer, wine, or wine coolers, or whatever it might be, it's all alcohol. So there is no safe time, no safe type, or no safe amount that is known at this time. All right, now this is those of you who have children, you recognize this is a typical growth chart that you might have seen a pediatrician show to you. And in this particular slide, you can see here this young boy who has the facial characteristics and has been diagnosed with FAS. And so this growth chart is oftentimes used during the first 3 years. And as you can see here in red, you can tell where his growth is in relation to where others are during that time period. Normal distribution there. He's at about the 5th percentile. So in terms of his height and weight, his growth has been significantly impacted. Again, this being one criteria that I mentioned early on as a diagnostic indication of FAS, the first being growth impairment. Here you have a picture of 2 young girls. You've got a typical child, a control child on the left side who does not have FAS. On the other side, you have a young girl who is diagnosed with FAS. And here you can tell some of the differences. You have this thin upper lip that is characteristic of a child with FAS. It's referred to as a vermilion border. That this is much different than this young girl who has a much fuller upper lip. You also have a smooth ridge here between the nose and upper lip. You see that there's not the normal kind of a ridge between the two. Hers is quite smooth. Oftentimes you'll also see that a shorter nose, again, smaller head circumference. Oftentimes the nasal bridge will be much lower, smaller eye openings. So these are some of the characteristics that can begin to help individuals begin to understand that this might be a child that could have this particular impairment, and would certainly at this point be something that you might, if you saw these facial characteristics, be thinking about a possible referral to a specialist to, in fact, determine whether or not that diagnosis would be accurate or not. We have an MRI, and I'm going to show you a couple of different pictures here. This particular image is one of a 9-year-old girl, and it's very typical, and you can't see it as well here, but what you have is a non-development of the corpus callosum, which is a connective tissue between 2 spheres. So between the left and right hemisphere, there's connective tissue that goes between that allows the left to communicate with the right and the right to communicate with the left. In this case, it's not developed. You'll also see a kind of a dark area right here that is just above the cerebellum, which is essentially empty space. And so this, you'll see in these other MRIs as well that the neural development, the brain development has simply been impaired as a result of prenatal alcohol exposure. So we're just seeing some of this here in terms of a different brain that we're talking about. And I'm going to continue to re-emphasize that over time, that we're really talking about a traumatic brain injury occurred prenatally that you'll see in a number of different slides here. This is one that, not an MRI, but a slide, a photograph of 2 brains. And you'll see here both of these 6-week old babies died of respiratory complications. The one on the left, as you can tell, having normal cortical development, whereby you can see the ridges and fissures, and the brain is fully developed at 6 weeks. The one on the right being a child that also died of respiratory complications that was diagnosed with fetal alcohol syndrome. Now, this is an extreme example, and one that I show with a little bit of caution so that people don't say, oh my gosh, every child that has FASD has this kind of a different brain. Again, extreme example, but it gives you a good idea of not just, oftentimes you'll see the corpus callosum, again, between the middle here, that hasn't been developed. You'll maybe see the frontal lobes or frontal part of the brain that's not fully developed. Here what you see is really a global impact. So oftentimes with injuries to the brain, it's specific to one area or the other. And you can tell by this photograph that this is something that's more global. So it's impacted the entire brain. It also gives you some idea, again, as I mentioned before, of this, and for those of you who might be parents or working with children who have fetal alcohol syndrome or have some of the other neurodevelopmental and behavioral kinds of deficits, that you're working with a child with a different brain. And it's sometimes difficult to, again, to retrain ourselves to think about how we approach working with these children different without understanding that they had maybe some blunt force trauma to the brain or something along those lines. But some of the traditional approaches we work, that we attempt to use with a child that is had a brain that's been impaired to this degree, just oftentimes don't work. So they frustrate us, parents, teachers, in trying to help them learn and grasp new ideas or to reach age-appropriate benchmarks along the way, because we're dealing with a child with a different brain, a brain that is impaired, that will limit their capacity to be able to learn in traditional sorts of ways. I mentioned also at the beginning here that there would be some central nervous system kinds of problems. I'm going to go through those a little bit here with you. Some of them being physical, so there may be delays in walking, gross motor kinds of skills, coordination kinds of problems. There may be a clumsiness, balance problems. You see seizures or tremors, coordinating hands and fingers, and some of the fine motor skills too that may be delayed. Dexterity isn't quite the same as it might be in a child. In babies, there may be more of a or sucking reflex. In terms of sensory difficulties, you'll oftentimes see integration problems. And what that means essentially is that we're taking in all this information and trying to make sense of it. Our brain's having to process and categorize and, again, make sense of the information that's coming in. And oftentimes, children with sensory integration problems, or these children that have spectrum disorder, they may have a more difficult time being able to do that. So environments that have a lot of stimulation in them, high stimulation situations, they may become very distractible and have a difficult time being able to transition into those environments. Transition is also oftentimes very difficult. Moving from one particular activity to something else, it might take a lot more time to be able to do. Have a difficult time managing that. The other sensory part of this that oftentimes is difficult for children is simply a sensation to touch. So there may be certain fabrics that are ones that are not processed the same way as we might process them. So there's a high degree of agitation, irritation associated with those fabrics because they're just so incredibly sensitive to touch. The other part here having to do with some other cognitive kinds of areas for social skills. Oftentimes, and this becomes one that may frustrate both parents and other caregivers, is attempting to figure out how they can help them reach age-appropriate behaviors, and they may be very inappropriate and much below what their chronological age is. So developmentally, they may be acting much younger, maybe more like a 3 or 4-year-old compared to like a 9 or 10-year-old, and they have very annoying behaviors that push them further and further away from peers their same age that have expectations that they will behave in a way that's appropriate to that age level. And so they oftentimes may get ostracized or pushed aside as a result of that. So they may be choosing friends that are much younger than them and oftentimes reinforcing the behaviors that they are exhibiting. They may lack certain fears of strangers, going up to people quite easily, may often get scapegoated by others, taken advantage of in those social situations. And unfortunately, in our world, not having good social skills can often be very detrimental in terms of one's capacity to be included, to be a part of groups, and can lead to incredible frustration and irritability. Some of these executive skills may include the ability to manage life tasks, being able to organize and plan. They may get very concrete in their thinking. incredibly uninhibited and not have an off switch. Uh, Cause and effect relationships may be difficult to grasp. Being able to think ahead and know that a particular set of actions are going to lead to a particular set of consequences. That, again, is a higher level cognitive skill that some of these children might not have the ability to integrate. Multi-step directions or confusing directions may oftentimes be ones that they have a hard time being able to discern or make sense of. So an example might be if you were to tell a child, pick up your room, being very concrete, pick up your room, becomes very confusing. So it's very difficult for somebody to think about this concretely, to think how it would be that I'd pick my room up. Again, it's one of those ways in which we're thinking about executive skills being limited, cognition limitations that are in place that we would have to think as adults or caregivers or teachers how we would word our sentences differently in order to accommodate some of that concrete thinking or judgment, whatever the situation might be. Doing things differently, changing routines, getting kids into routines that are often the best they could possibly do, just with typical or normal children don't have a spectrum disorder, but you may have a very difficult time changing routines, and it may be a huge upset to their system and what they've developed and what they've become comfortable with. And so this can oftentimes be a very difficult transition for them. Learning, as I mentioned before, although we may see sometimes good verbal communication skills, oftentimes they may have a slower processing time. Math is often a subject that they are most limited in, or grades in school. Difficulty with carryover. So oftentimes we have frustrations associated with attempting to teach children one day and then the next day not having that foundation. So that foundation doesn't oftentimes exist. So we may have short-term memory problems, and there's no foundation that continues to allow and us as parents or teachers to build from one day to the next. It becomes frustrating and difficult on both sides. I have here I'm going to try to move out of the sun here a little bit. As I move around, that might be better. A framework for moving for a diagnosis and what happens in this referral process. So it may be that we see certain limitations, or we may see difficulties with certain central nervous system or age-appropriate benchmarks you'd expect children to achieve at certain levels. This may be just developmental, but there may be a combination of factors that might enter into that, including the mother's consumption of alcohol during pregnancy. There may also be the facial features that would lend some insight into the fact that we may need to look for a possible diagnosis so this kid could get the services he or she needs. Now, there are professionals that sometimes may have a hesitancy to do that, knowing that it would immediately implicate the biological mother if, in fact, a positive diagnosis was made. But at the same time, most professionals are able to figure out how to navigate that successfully by both preventing the possibility of another FASD-related birth down the road because the mother would have the information she might not have had before. And then we would also have an opportunity to begin to, again, if in fact the diagnosis by a specialist was made, to involve that child into certain kinds of services that they otherwise wouldn't be eligible for. So many of you might be very familiar with disability services and some of those services that states do and don't provide. And if you do not have that diagnosis, the chances of getting those services are incredibly limited. And early intervention is significantly important. And so that early intervention, early beginning is incredibly important in order to make sure that that child has every opportunity possible to get the services he or she might need to move forward. Many of these services take place through federal sources. The Individuals with Disability Education Act, or IDEA, as both Part C and Part B that are specific for children who have FAS and may have other kinds of disabling features that would limit them in some way. And again, having the diagnosis allows for the opportunity to have those resources available. I'm going to now go ahead and stop my microphone here for a minute and I'm going to keep my microphone open. I'm going to take questions, I think, here. And then we're going to go ahead and show a video of a woman who is an occupational therapist. I like the way that she describes some of the work that she does with children with FAS. And I think it'll give some more information about some of these central nervous system problems and sensory integration problems I talk about. So we'll go ahead and get some of the questions here. Carolyn, I'm not sure if you're going to move here or not.
Yep, we so far have one question from Megan. She's asking, do those childhood inabilities last throughout one's lifetime?
Yeah, it's a good question, Megan, and it was the actually the focus of my dissertation work was in that specific area because it was something that I was wondering if would be just limited to childhood or youth, and unfortunately, it's not. So it is a lifetime disability. It's not something that would go away. Certainly, there are ways in which individuals can begin to compensate for some of those limitations beyond childhood and adolescence as they become adults. So they've got ways of incorporating those limitations, learning new strategies and skills, building on the strengths that they possess, but it is something that lasts a lifetime.
All right, at this point, it doesn't look like we have any questions, but I'd like to give participants a minute or two to type any questions they have for our presenter in the chat box. And I just want to remind you, if you haven't had a chance to take the pre-test for this webinar, please do so at some point. We will be offering the post-test at the end of the webinar. And also, if you did sign in with just your first name, please make sure to contact myself or Tricia, our other moderator, and give us your last name. All right, it looks like we have Emily typing right now. And Ryan, are you okay with me getting the video started?
Yeah, that'd be fine.
Okay, and for those of you who have a slower internet connection, you are probably going to have some difficulty hearing or viewing the video. I have included the link to the video in the web links box. It's called OCC, Occupational Therapy Video with Joy Dahl. So please look at that video when you do have a chance. And sorry, Ryan, Marina asked really quick, do you know if autism is connected to FASD?
Typically not. The two might at some point overlap. There could be a child that has autism that would also have a fetal alcohol spectrum disorder. So it is possible. I have not run into that, and I imagine that it could be incredibly difficult to diagnose, as your question appears here, especially if those physical characteristics weren't present. So the limitations in communication with a child that would have would be on the spectrum for autism would be difficult to discern from the central nervous system problems of FAS or any type of FASD. Trying to weigh those against those that might be specific to autism.
And Emily asks, can you discuss how difficult it is to diagnose when there are no physical characteristics of the syndrome?
Yeah, it is very difficult, and this is a place where you'll have practitioners who are using the DSM-4R that will get into situations in which they may diagnose in a different way. So they may lean more toward a oppositional defiant disorder. If, in fact, this is something that you'll see some of these FSD characteristics that are occurring in adolescence, where you oftentimes have them getting involved with the justice system. So all of a sudden, you may be turning to the DSM rather than getting a medical diagnosis at that time, or there may be limited access to a physician that could accurately diagnose the condition. So there are oftentimes confusion between the two. There's some inaccuracies that occur in attempting to diagnose, especially as you get into adolescence and adulthood, and frequently they end up with a mental health diagnosis that may not be entirely accurate with their condition. That then oftentimes has a detrimental impact in terms of the way in which treatment proceeds. So if the diagnosis isn't correct, how is the treatment plan going to be consistent with the limitations that might be in place? So you might not be able to then account for some of the central nervous system deficits that might be there if in fact there's a preoccupation with many of the behaviors that are being displayed that are perhaps being viewed as a result of parenting or bad environment or more environmental conditions when in fact it's more biological.
All right, it looks like we're getting a couple of comments, and I will read our next question. Wouldn't a diagnostic team be needed with training in FASD?
Yeah, that would be the most ideal. A diagnostic team, again, I'm here in Montana. Back in the 1980s, we didn't have that. We have more teams available now that can provide that. In this state, that particular team is located in Helena. So we may have people that have minimal amount of income to have a diagnostic team move forward with a screening process or a complete neuropsych eval or anything along those lines, and so they may not be able to provide that diagnostic team approach, which would be the best possible scenario. But there are, again, pediatricians, dysmorphologists, especially, and neurologists pediatric neurologists that would also be able to provide that diagnosis.
Okay, and Capri says, handling the FASD youth who eventually come through the system, is there a way their probation plan should be modified to accommodate the family?
Yeah, it's dependent on the involvement of the family. Certainly, most of the kids that hopefully are youth probation and parole, so the family they haven't burned enough bridges at that point to have the family completely abandon them. Which oftentimes is the case when you end up down the road in these systems. They end up by themselves and estranged from any family members, whether they be biological or foster or perhaps other kinship providers. I think part of it is making sure that they understand that what they're contending with is not willful behavior. So we'll get into that a little bit as we move through this. Oftentimes people get stuck on what they see on the outside. What is annoying? What is irritating? What is present, and what could potentially be viewed as easy to change if one made the choice to do so. I'm not saying that we then get in a position where you say, well, gosh, they're destined to behave this way, but at the same time, they're limited in their capacity to be able to do it because of some of the cognitive limitations that are in fact. And having families understand that the brain is limited in its ability to be able to change, to adopt new behaviors, is oftentimes very helpful for them to be able to at least begin to empathize with the fact that there may be limitations in terms of this person's behavioral changes, and they're going to have to approach this person in a different way. As we get to the second half, I'll give you some resources that will help you perhaps in that process as well.
Okay, thank you, Ryan. At this point, we're going to start the video, but please keep your questions coming and we will address them at the next question break. And Ryan, I just want to remind you to mute your microphone.
My name is Joy Dahl. I'm an occupational therapist by training. Occupational therapists focus on things people do every day that are meaningful, so we help people do their daily activities, basically. Research tells us that 85% of kids with fetal alcohol spectrum disorder also have sensory processing disorder or sensory issues, which means that they can be hypersensitive to sensory experiences, like their clothing is uncomfortable to them, sounds bother them, they can't focus, or they can be hyposensitive, and those are your kids that unintentionally hurt other children or animals because they don't have good body awareness because of the damage in their brain from alcohol exposure. So they may break toys or hurt other children because of their lack of body awareness. So the role of OT is to go in and assess the child, meet with the family, and figure out what their sensory issues are, and then help develop often what's called a sensory diet to help the child learn to manage those sensory issues more effectively. You can think about prenatal alcohol exposure as a TBI in the womb, a traumatic brain injury in the womb, and it literally kills the neurons, so they just never develop. And when you kill them even though we generate new neurons our whole life, when you kill them like that in the womb, they never have a chance. So that's why their brains are small and don't have a chance. But it doesn't mean they're not plastic and can't change. It puts them at a significant disadvantage. Many children with sensory issues get labeled as bad children or have behavioral issues when they're actually having a stress response to sensory overload is really what happens. You have to think for yourself what it would be like if you go in and you felt the tag in your clothes all day, and how that would feel and how it would be hard to concentrate. And if you try to put yourself in those shoes, you can see why OT can help intervene and help with those things. And the answer can be as simple as tagless clothes or cutting the tags out of clothes. We've had instances where we put colored tape around a child's desk and say, you can fidget as long as it's within this tape. Another strategy is to place the child on a therapy ball and have them sit on the therapy ball. That allows them to fidget kind of naturally without distracting other children. So it's all individualized. A child that had poor oral motor control, so they didn't have good lips, and so they drooled, and they were in the 2nd grade. And drooling in the 2nd grade, totally socially inappropriate. So the OT got these like cool looking sweatbands that the kid like wore on his wrist, and that was what he wiped to get rid of the drool. So it didn't look like uncool or socially inappropriate, and so he could kind of do that without it being obvious, and he had different ones and different styles to match his clothes. I thought that was a great strategy. Children with FASD, a lot of times you see damage to the frontal lobe of the brain, and the frontal lobe is your inhibition, your executive functioning. So that's the part of your brain that you may think a curse word, but it doesn't come out. But children with FASD struggle because they have damage to that area. So they may say that curse word, or they may say, wow, your shirt is really ugly, and they don't have the ability, because of the brain damage, to realize the social consequences of that. They may comment on a picture on Facebook, and it sounds very mean. But they're just being very honest about what they observe, very concrete, because abstract thought is very challenging because of the brain damage from prenatal alcohol exposure. Anyone can post something on Facebook, even a normal person, and be misinterpreted or be mistaken. I mean, that happens all the time with people that are very intelligent. So I would say minimize the use and exposure to social media. Children with ADHD, which is very high prevalence in kids with FASD, they love media because it's constantly changing the environment, and that's how their brain kind of works. They can jump from one thing to the other very efficiently. That doesn't work well in our school environments where you're expected to pay attention to something, but with media that works really well because you can switch and it goes fast, and they can play video games for hours because it's constantly changing. Parents of children with FASD should definitely seek out an occupational therapist. Don't struggle if your child has sensory issues or is struggling in school. There's people that can help you, and an occupational therapist is a great place to start because they'll work with your child on those daily, day-to-day things, and we understand, at least can empathize working with other parents, what it means like to parent a child with these disabilities, and that it is possible, connecting you and getting you support and resources to help with your child. And each child is unique, and we understand that in occupational therapy.
Great, I'm back, and I've been looking at some of the questions that have been placed here on this chat board, and I want to let you know that I'll have time at the end of this presentation to get to those. As I make my way through these last few slides here, I want to make sure that I get this last bit of information, but if you're able to hang on a little bit past 1 o'clock, I will answer the questions that have been posed here to make sure that we get to those as well. This I mentioned this a little bit before, some of the cognitive deficits and the impact in certain areas having to do with academic learning new skills and behavior, reaching those age-appropriate benchmarks, the social skills, the age-appropriate behaviors being ones that oftentimes limit then some of these children's capacity to be included or a part of same age groups with their peers, and oftentimes being ostracized to some degree. We also then have often employed traditional approaches with them that are typical for children that might be able to respond to some of the ways in which we might teach or correct behavior that don't work. And they end up frustrating us as professionals and adults trying to figure out why this child isn't behaving a certain way. If they just tried harder, they could do better. This is willful, it's just a stubborn child. Or oftentimes we might just start to blame caregivers or parents for the child's behavior, when in fact, as I mentioned before, this is a different brain that we're contending with. So although the environment may certainly play a part in that, we're looking at children that are predisposed to these behaviors, and there's a high likelihood that they'll behave a certain way if in fact the approaches aren't changed. Us adults aren't making changes in order to accommodate that child's unique needs. So we might be giving timeouts, we might ignore behavior that's inappropriate or problematic, expecting that the child would get or understand that this was not acceptable, when in fact they would not be paying attention to those social cues the same way that a typical child might. So we become increasingly frustrated by the fact that that's not taking place. And again, they blame the child or blame parents or whatever other environmental factors there might be, when in fact it's the approaches we're taking that aren't accommodating the unique differences, and I'll say the unique biological or neurological differences of these particular children. So part of what I hope that folks walk away with here is, in terms of thinking about how to work with these children, is we have to approach it differently. We have to evaluate those traditional methods and approaches to teaching and disciplining or correcting children, and be willing to adopt new strategies and new techniques. Now, one of the resources I'll have at the end of this set of slides is a book that's called Trying Differently Rather Than Harder. This also gets to the probation and parole issue a little bit as well. The woman's name is Diane Malbum. And again, it'll come at the end here with a slide that will show a number of different books. But this is one, I think, that explains very well some of these differences, so that we as professionals can understand it, parents can understand it, everybody can understand that this is a different kind of child or adolescent or adult that I'm contending with here. And my traditional approaches need to be modified. We need to make those changes in order to accommodate those differences so we have more success. All right, I'm going to move a little bit here into this prevention end. And those of you who may be working in the area of prevention have a chance to think a little bit about screening. The Center for Disease Control and Prevention is recommending that all women of childbearing age be screened to determine their alcohol use. Again, all women of childbearing age, because of the prevalence rates, because women don't always know exactly when they are pregnant, that they were recommending that there be some sort of screening that's provided in order to reduce the likelihood or prevent an FASD birth from occurring. Now, this may be in emergency room settings. It could be another primary care, whether it be primary care, a public health center, those kinds of areas where there may be an opportunity to get some kind of a physical history, that there would also be the opportunity to have some opportunity to ask questions along the lines of drinking behaviors, and get a better idea of whether or not a woman may be at risk or not. Now, there oftentimes are many reasons why people might not do this, and part of it has to do with training. And so many individuals in the healthcare industry might say, well, that's not my role. I may be providing a different kind of healthcare role, rather than it being asking or counseling or assessing whether or not a person has an alcohol problem. Or it may be that that's not why they're here, or there may be a personal discomfort with asking personal questions along the lines of alcohol consumption. Part of this is those of you who may be working in this area getting more comfortable with your discomfort around this, as the research shows that patients are perceiving that the screening and brief intervention process I'll mention here in a little bit is a part of that healthcare worker role. It may be that you may have certain policies and procedures in place that may limit what role you play with working with some of these women, but I think the discomfort with it may be on the professional's end more than it may be on the end of the patient or consumer. And it may be a matter of getting additional training in order to figure out how that process can begin to occur. There are many simple screening instruments that are in place. There's some suggestions I'm going to make here that could help with that process. Now, one that I have listed here is that we would avoid the confrontation or the moralizing of this being wrong, that you absolutely can't drink. This is a bad thing, a wrong thing. and it just can't occur in a way that would, I guess, point blame at the mother. Now, this is a place where self-awareness is very important. I would like to change a lot of people's behaviors, but what I have come to realize is the more that I attempt to confront them with problematic behaviors, the more likely they are to resist and dig deeper and stronger trenches to stay exactly where they're at. So it's important to make sure that you're self-aware here of your own values and how those values might impact perhaps a desire to be confrontational. Again, they're likely to dig deeper trenches, resist any kind of intervention from that point in time, if in fact there is a moralizing or preaching or a confrontation about that behavior being wrong or incorrect or inappropriate or something along those lines. So as best you can, you're gonna have to figure out how to remain supportive and non-judgmental. Doesn't mean that you're not holding people accountable. It doesn't mean that we can work on problematic behaviors, but we can do that in a supportive, non-judgmental way. The two can coexist. Now, there are higher prevalence rates among those who are of a lower socioeconomic scale, those that are American Indian or Native American or African American, smokers and other drug users, polydrug users are oftentimes at higher risk. But again, as the CDC recommends that all women of childbearing age be screened, I don't want you to get into a false sense that, well, it's those that are higher risk that I better be paying closer attention to. So there are many women that may be middle class or different, maybe where clothes indicate that they're educated or have good jobs that are also potentially at risk. So you've got to really make sure here that you're looking at all women as being potentially at risk or even be screened to see whether or not they're at risk, rather than assuming it's going to be just those people that demonstrate certain kinds of characteristics that you would begin to screen when you have that opportunity. Now, there is a question that is oftentimes asked in here, these two instruments I'm going to show you here in a minute, asking a question along how much do you drink? And what a drink consists of is fairly subjective. A standard drink is what I have listed here: 12-ounce beer, 5% alcohol, 5 ounces of wine at 12% alcohol, or 1.5 ounces of liquor, 40% alcohol, which is 80 proof. So maybe that, again, there may be microbrews that have a higher alcohol percent amount. There may be somebody who says, well, I only have 2 beers, but they may be these very large containers of beer. Pints are larger that would consist of more than one drink. So part of it is making sure you understand what they would consider to be a drink so that you have some idea of just how much alcohol is being consumed. Now, 2 screening instruments that we have here, the CDC recommends: the tweak and the taste, simply acronyms for what we're going to talk about here for just a couple of minutes. I'm going to also bring a poll over here. Carolyn's going to bring a poll in here to ask you what you think this first letter stands for. The tweak and the taste, what the T stands for here. People go ahead and see what it might include. No wrong answers here. We won't know who has answered what, so don't worry about being incorrect. Looks like here the vast majority are going for tolerance. Put a couple other big words in there, try to throw you off a little bit. But yes, it is correct that the tolerance is the first question that's being asked in both the tweak and the taste to find out just how tolerant an individual might be. So that first question is one that falls along the lines of how many drinks can you hold, or how many drinks do you need to take in order to feel high? And as I go through these two, you'll see that there's consistency between the two. I'm looking at the time now. I'm not going to have time to go through all of these, but tolerance, worry, whether or not close friends or relatives are worried about your drinking pattern. These are both of these tweak or taste. Those of you who have a chance to look up and find out more about them are easy to administer. They only take about 5 minutes or so to ask these questions, maybe 10 minutes. Again, if there are severe time limits, the CDC recommends that there just be one simple question that's asked here. For pregnant women, have you had a drink since you found out you were pregnant? If the answer was yes, they proceed then with some type of brief intervention. The last one here, for non-pregnant women, a single question that could be asked to alert somebody of whether or not they should proceed with some kind of again, a brief intervention, which I'll go through here for just a few seconds. So here's the brief intervention consists of this frames model, giving feedback of personal risk. So with a tweak of the taste, if an individual scores 2 or higher, they are at risk. And so giving that information to that woman would be helpful for them to then know that there is in fact a risk here, that they have personal control or personal choice, making decisions about where to go from here. And the tweak in the taste isn't designed to diagnose alcoholism or an alcoholic, but it's just that there is risk and that some kind of intervention is necessary. Providing some degree of advice to change, make an alteration in terms of drinking behavior, a number of different options of ways to reduce or stop drinking, providing empathy. Again, this is the support and being non-judgmental during these particular portion of the brief intervention. I know for some of you who may be working in residential treatment programs, perhaps with young girls that may be pregnant, consuming alcohol might have a different level of empathy. It doesn't mean empathy can't coexist with accountability and high expectations, but remaining non-judgmental and supportive, in addition to having certain expectations and holding people accountable, that can all go together. The final piece here, self-efficacy, or you have the ability to do this, that there is the possibility of making this happen. We'll provide resources and support to make that occur as part of this brief intervention model. That's the last of the slides here. As I mentioned before, a number of questions that were being asked I think would be answered quite well with these 2 books that I have listed here at the top. Trying Differently Rather Than Harder by Diane Malbum is one that I've used for many years and have had professionals and parents look at so they would have a better idea of what it is that they're dealing with in terms of some of the thinking differences, some of the behavioral differences, and what kinds of approaches would work best in order to accommodate those differences. So both Trying Differently Rather Than Harder and Fantastic Antone Succeeds are 2 books that would help with that. We also have other internet resources here that could be of help for those of you. NoFast was the internet source that we use that video for. There are many other videos they have that are available in addition to alcohol-free pregnancy, another resource online that is very helpful. I think there's another one after this too. Here you have a number of other sources here that could also be resources for individuals as well. So what I'll do is go ahead and stop there and thank you for your participation. We're at 1 o'clock and I will stay online here for a little while and try to answer some of these questions. I know those of you may have appointments you need to run to, so if you're able to stay, great. Otherwise, thank you for your participation.
Great, thanks, Ryan. And like Ryan said, we're going to be sticking around to answer some questions that I've been compiling for Ryan. But I wanted to let you know that we do have the webinar post test available, so please click on it in the web links box and press the Browse To button. That will bring you to the post test, and we would appreciate your participation in that. I will be emailing you your certificate of completion and a copy of the PowerPoint presentation in a PDF version within the next 2 weeks. And once again, if you didn't register for the webinar, please contact me so I can get your information so I can give you a certificate of completion. And if you have any questions for myself as the moderator, please type them in the chat box as well, and I will try to address them. And so I'm now going to go over some questions that we've received for Ryan. So a while back, Rose said, I was told that it is not needed to know the maternal alcohol intake for a diagnosis if enough other symptoms are there. Children adopted not always come with histories. Is it absolutely needed to know the maternal history, especially if your child is adopted for a diagnosis?
Yeah, I think I might have saw that question move its way through that chat room, and Rose is correct. And I think as the way I understand the question, there does not have to be confirmation of maternal consumption of alcohol during pregnancy. she's absolutely right. There are many children who come into the system where you don't have that history. You don't know. And the other characteristics, as I mentioned, FAS having three defining features, and I didn't include one that has to do with maternal consumption of alcohol. You would think that would be a requirement, and it's not.
Okay, so Marina just had a couple of comments. They're not questions. She says, I'm an educator and family therapist and encounter so many children with FAS throughout my day. I sub in a district that seems unaware of the problem. Many years ago, my focus was ADHD, and now I realize that they were FAS children. I can now see it in their faces and many other characteristics, but the focus used to be ADHD. So that was an interesting comment. Thanks, Marina, for that. Daniel's question is, how much will diagnosis be improved or easier when and if FASD is ever included in the revised DSM?
Okay, I don't see the question here. It must have been a ways back. And I'll make sure that I understand this correctly. The revised DSM or the DSM-5 will not include it as a diagnosis that's available for psychologists, psychiatrists, licensed professional counselors, LCSWs, and it will remain as a in the PDR, and physicians will be the ones that will be making that diagnosis. So I think that that's the question, but it is not something that's
great. Thank you.
DSM.
Geraldine says, I am a foster parent with 3-year-old twins. One child has significant facial features to suggest FASD. The other twin does not have the facial features. Have you seen that before? Both children have speech and developmental delays.
Yeah, I saw that question during the video, and I have seen something like that. And it may be, even despite the fact that they're twins, that one may be have been exposed more significantly than the other, and so it may be possible that the deficits may be different. And so it's good that you notice it this early on, and if there is the possibility that you could have and as was mentioned earlier, a diagnostic team or somebody who has expertise in this area that could begin to make sense of and do a full sort of neuropsych eval in order to see whether or not one may have FAS, one might not, one would qualify for services, one might not, maybe they both would. But the earlier you get that screened, the better likelihood they would have of maximizing their potential so that they would get involved with professionals that could help them very soon. And it could be that one has very specific deficits in one area and the other does not. And so it could be that one just may have been affected.
Okay, Wendy is asking, does extensive alcohol usage prior to pregnancy have any effect on a fetus?
No. It certainly could have you'll notice the chart that I put very early on, there was a window, the first 2 weeks, and during that time, it's in an ovum stage before it becomes an embryo, so it hasn't connected to the uterine wall. And during that 2 weeks, actually, there is no, at least the latest research indicates that there's no damage that can be done during that ovum period. It's not until it attaches to the uterine wall that it begins then to take nutrients from the mother and gets impacted during that week 3. So prior to, if there was a lot of drinking prior to pregnancy, that may have other kinds of issues or problems, but it wouldn't impact then neural development and lend itself to fetal alcohol spectrum disorder. It would happen, again, specifically to alcohol consumption during pregnancy beginning in week.
All right, Rose is asking, is it true that most of the social, emotional, inappropriate behaviors seen in children with FASD are not primary characteristics of FASD, but rather secondary symptoms due to inappropriate interventions?
It could be true. If you think about it in terms of cognitive deficits or neural delays, the fact that the limbic system, that midbrain portion not being fully developed, where communication, memory, and emotion exist. And so some of what you're talking about in terms of some of that development is going to be specific to limited neural development. Now, it can then be exacerbated by environmental conditions whereby, whether it be peer influence, whether it be family influence, or whether it be socialization process and opportunities that are made available either by having early intervention available or not available, or caregivers responding certain kinds of ways that may be specific to accommodating those specific kinds of impairments, it certainly may exacerbate or make worse than those particular areas, social, emotional kinds of development that otherwise could be minimized if in fact there was a specific plan in place and everybody was on page with that plan and responded in certain ways. And that would include caregivers, parents, maybe extended family members, teachers. So often we have inconsistencies between those that are part of that system that make up a child's life, that there may be one that in fact is contradictory to the other three. And if all aren't on board, you've got a situation that may end up limiting that child's capacity or to maximize their potential.
All right, it looks like we have addressed all of the questions. Some comments have been coming in, so feel free to read through those if you'd like. For the other participants, please type your questions for Ryan right now. We will be ending soon. And also, Sonia, you signed in with only your first name. We do need your last name, so please enter that in the chat box.
This group, this group ended up putting that they didn't know much, but I'm finding based on the comments that they're typing that they actually do. So I'm not sure they were telling us the truth from the very beginning. I don't think I've gotten so many great questions.
And I just wanted to take a moment to point out a comment that Louise made. She said, as a frustrated parent of a teen with FASD, thank you for reminding us that we must take a different approach. It is easy to forget in the midst of the day, but critical to help our FASD children. I thought that was nice.
I appreciate that, and it's something that is so easy for us to instinctually react to what we see on the outside. And so we see annoying behaviors, we see irritating personalities, and that's what we react to. And it's important to make sure that we understand what's behind that. And in this case, what's happening in terms of cognition, we need to make sure that we're responding to that. So we can understand and empathize with that behavior rather than simply being put off or irritated by what we see on the outside. I'm not saying that's easy. As a parent with 4 children, oftentimes reacting to what we see on the outside that can be irritating without thinking about what is it behind what I'm seeing externally that I need to pay attention to. There's emotion that drives this, there's cognition that drives this, there's limitations developmentally that drive this, and if we respond to what we see on the outside, we're not going to be very successful in being able to understand what in fact is going on with these kids and how we can potentially meet their needs better.
All right, there's a last question from Rose. How long does it take for alcohol to leave the woman's system if she has sexual contact? Can she get FASD like if she drank a day before sexual contact?
Yeah, again, and I don't know the answer to this, and I think it would depend on a few different factors in terms of a young woman's capacity to metabolize alcohol. Part of that metabolism process is also affected by a diet and the amount that's consumed. And so those would be variables that would affect that. Again, as mentioned, if that happened before pregnancy or in the early part, let's say in the early part of pregnancy, that during that first 2 weeks, it wouldn't affect it. So it may be that then it happening in week 3 and beyond during that first trimester, that in fact, if she drank a day or was a binge drinker or something along that lines, that metabolizing process could take some time. And again, it would depend on a lot of different factors. But certainly that would be a situation in which that embryo or that fetus would be exposed to alcohol during that time period, and week 3 and beyond during that first trimester. That would be most.
All right, I don't see any more questions coming in, so at this point I'd like to thank Ryan for your time, and we appreciate your information and knowledge. If anybody does have questions after the fact for Ryan, you can contact me, and I can pass the message along to Ryan. Or if you want to stick around for a few minutes, Ryan probably has to get going, but I will stick around and take your questions that I can pass along to Ryan. So at this point, you can sign off, but please make sure to complete the webinar post-test, and thank you for your time today.
Great, thank you.